It's my honor to introduce our first Grand Round speaker, Dr. Nishi Dedania. Dr. Dedania is an assistant professor of clinical medicine in the Division of Internal Medicine and Pediatrics. She completed her medical school training at the Thomas Jefferson Medical College, followed by combined medicine pediatrics residency and chief resident at the University of Illinois, Chicago. Before arriving here at the U, she served as assistant professor at Brown University. She has interest in medical education and serves as faculty preceptor, developing GME courses and curricula, and in residency selection committee throughout her career. Has published and presented in national meetings her work in improving formal didactics and teaching in internal medicine wards. She was nominated Outstanding Graduating Resident of the Year at UIC and received the Internal Medicine Inpatient Teaching Award at Brown University. She's beloved by all the residents as a great teacher and mentor. It is my distinct pleasure to welcome Dr. Dedania to Grand Round.
Thank you for those kind words. Hello, everybody. I'm Nishi Dedania. Today, I wanted to talk about adult congenital heart disease from the perspective of an internist. I have a case of a patient that I saw initially in my own internal medicine clinic, who then ultimately ended up on the inpatient side as well. My learning objectives today are mainly to define and recognize congenital heart disease in adults. I want to build a framework for classifying common lesions and how to review the complications that present in adulthood for those patients. And ultimately, we'll talk about the importance of a planned transition process for patients who have congenital heart disease. I have no financial disclosures. So the chief complaint for my patient initially presented to my clinic for pre-op evaluation. She's a 65-year-old female. She has a history of multiple myeloma. She was recently diagnosed with breast cancer, diabetes, hypertension, and she's coming in presenting for a pre-op evaluation in anticipation for a lumpectomy. On talking to her, she really stated she had no complaints, but getting into a little bit more detail, she did note that she had some lower extremity edema that started maybe about a year ago. It's been worsening over the past couple months. She endorses some mild dyspnea on exertion, but no other associated cardiac symptoms such as chest pain, orthopnea, any palpitations. When you look at her chart, her past medical history is mainly as what was stated prior: hypertension, diabetes, asthma, the multiple myeloma, and breast cancer. Her medication list correlates with that past medical history. When I started asking her more from a perioperative standpoint, asking if she had a history of stroke or any other cardiac disease, she actually did state that she had a stroke twice in her 20s, back in the 1970s and early 80s. When I asked what they thought the stroke was from, she said, well, I have that hole in my heart. And I thought that was quite interesting because throughout this time, in her being 65 years old, that has really not been captured in her chart up until this time, which is one of the main points that comes up when we talk about adult congenital heart disease. When I asked in the history in her 20s what they had said about her congenital heart disease, she had stated that it was recommended at that time that that cardiac defect be closed, but she did not want to undergo open heart surgery, and so she had refused at that time. She had had a cardiologist for many years in the community, again, not captured in our medical records here. And when that provider retired, she felt well and didn't think that she needed a cardiologist anymore, and so had been out of care from a cardiac perspective. On her exam, her vitals are listed. They're stable besides a slightly low blood pressure, but she was feeling well. And then notable on her exam was mild JVD, a murmur, a 2 out of 6 holosystolic murmur, and 2+ edema to the mid-shin. This is in my clinic. On chart review here at UM, I did see an echo from May the prior year and February of this year as well. The indication was for possible stem cell transplant given her multiple myeloma. And the main points from this echo I wanted to point out are normal or preserved LV function, also RV function at this point, but it did note dilated RA and RV, actually severely dilated right atrium and moderately dilated right ventricle. They really didn't comment on the ASD at all. We repeated an echo in light of her new onset heart failure symptoms. We indicated that we're looking for congenital heart disease in our indication for study. She still had preserved LV function, but this time we have dilated right-sided chambers, but also a reduced right ventricular function. And they did note the large ASD at this point with left to right shunting. Over the course of this case, between getting the outpatient studies done and getting her evaluated in our cardiology clinic, she came to our clinic 3 more times. Despite starting her on medications, she presented with progressive volume overload. The echo was in June, as I mentioned on the prior slide, and ultimately she did end up getting hospitalized for acute decompensated heart failure. At that time, cardiology evaluated her in the hospital, and she was recommended to get an ASD closure by endovascular approach. Unfortunately, in the hospital, she contracted a URI and felt quite symptomatic, had a lot of respiratory symptoms, and felt that she wanted to recover from that prior to her ASD closure. So she herself left the hospital. And then currently, we're still 3 months, we're 3 months now later from her presentation, when she was cleared for the lumpectomy and actually had that procedure, but she still has not had that ASD repaired. So the main reason I wanted to bring up this case is that it represents a pretty classic presentation of adult congenital heart disease. Often lesions are either unknown or they're forgotten. They may have known about this in their childhood and they consider themselves either cured if they had a procedure done in their childhood, or they're really just asymptomatic. And so these lesions are often missed or misdiagnosed. And the goal of my presentation is to really present this fairly typical case and put it in the framework and in the light of congenital heart disease and thinking about the special considerations that these patients need in their care. So I'd like to start by just defining congenital heart disease. It really encompasses structural heart disease that's present before birth, that's really attributable to cardiac development. We're not talking at this point, when we talk about congenital heart disease, about genetic or inherited diseases such as Marfan's or hypertrophic cardiomyopathy. We're really talking structural developmental diseases. When we talk about congenital heart disease, this is, as I had mentioned earlier, a classic presentation. Congenital heart disease affects about 1% of the population. And since the 1950s, really, survival has increased for a lot of pediatric patients with congenital heart disease, to the point where the expected survival to adulthood is above 90%, even for severe congenital heart disease, the cyanotic congenital heart disease lesions. And this is really thankful to, as I had mentioned in the 1950s, cardiopulmonary bypass, and then multiple surgical and endovascular procedures that are now available to these patients. So our survival rate has just increased tremendously over these years. Back in 2010, it was estimated that there are about 2 million adults with congenital heart disease in the US. And at this point, it's actually estimated that there are more adult patients with congenital heart disease than there are pediatric. In these two graphs, you can see that change in prevalence. The graph on our left talks about prevalence from 1985 to 2000 within each age group. And even in 2000, as you look in this age, the young adult teenage years, there was into the year 2000 a rise in the cases that we were seeing in this age group that has only shifted as these patients live longer and longer. So we are actually anticipating now that the shift has really become more into the adult ages when we talk about the prevalence of congenital heart disease. On our right, this graph really just illustrates that we should be expecting more and more hospitalizations and hospital encounters for adults with congenital heart disease, our dark graph, as opposed to our pediatrics. And so when we talk about congenital heart disease, the majority of care that we're going to be providing is within the adult realm as we move forward. So when we're talking about congenital heart disease and their typical presentations in adulthood, we're looking for mainly TIA, stroke, arrhythmia, valvular disease, which includes endocarditis in this, and heart failure. There are other presentations, but these are the most common presentations for typical lesions from congenital heart disease standpoint. I want to point out this resource because it's really provides a wealth of knowledge and a good reference. When you have a patient who you may not know what to do with their congenital heart disease, it's a great reference to know about from the ACC-AHA. It's the updated 2018 guideline for the management for adults with congenital heart disease. So when we classify congenital heart disease, we're really talking, I want to put lesions into about 4 different buckets. There are very complex diseases, and everybody's pathology does not always match their anatomy. So within that guideline, there actually is a classification system that takes into account both of those. We usually classify based on anatomy and their physiology. I break things down into shunt lesions, left and right-sided obstructive lesions, and then more complicated lesions. So within each of those buckets, these are the most common lesions that we'll probably find, but it's by no means an extensive list. The ones that are highlighted here are the lesions that I want to go over today, because I think as an internist, an ASD, VSD, coarctation, and tetralogy of Fallot are really the main lesions that we are most likely to see in our own day-to-day practice. So when we talk about shunt lesions, we really break it down into pre-tricuspid and post-tricuspid. So pre-tricuspid, we have an ASD as our classic shunt lesion. We're shunting left to right and often will lead to right-sided heart failure. When we're talking post-tricuspid, the 2 lesions that I would think about are the VSD and a patent ductus arteriosus. Often that will lead to left-sided heart failure, but that is with a caveat of normal pulmonary pressures. The main side, where left or right, where you see chamber enlargement, is also related to the volume and the amount of volume that is shunted from left to right. So within an ASD, this is a common lesion. It presents variably depending on the type of ASD. There are a couple different types, and the size of the defect and the size of the shunt. The complications that arise from an ASD are really related to those factors. How large of a shunt is there? If you get right atrial and right ventricular enlargement, that often predisposes to various types of arrhythmia, including atrial fibrillation. So it's one of the things that we should be monitoring for in our patients. The volume leads to pulmonary hypertension, cryptogenic stroke, as in my patient, just because of that abnormal connection between the right and left chambers of the heart. And even after repair, these patients should be monitored for a residual shunt. So they may still have developing pathology because the repair may not be complete. Now, indications for treatment usually involve hemodynamics, a hemodynamically significant shunt that has shown evidence of right-sided overload. And the idea here is that you also want to repair prior to long-term complications such as elevated pulmonary pressures, which if you did close at that point, the patient would not tolerate from a hemodynamic standpoint. There is a treatment algorithm within the guideline that I had mentioned that kind of outlines when and what type of repair a patient would qualify for. Next on our list of lesions, I wanted to talk about ventricular septal defect. This is the most common pediatric congenital heart disease. Obviously, it involves a connection within the ventricles of the heart. Here, the complications that I most commonly think of are Eisenmenger syndrome, which is a syndrome in which the pulmonary pressures equal the systemic pressures. And so instead of getting a left to right shunt within this lesion, the shunting actually reverses and you can get a right to left shunt as well. I also think about endocarditis, and the endocarditis I think about are both tricuspid and pulmonary valve typically. You can get aortic regurgitation, and this is even in small VSDs that are not necessarily hemodynamically significant. There is still a shunt jet that leads to AV prolapse, and so ultimately with a VSD we should also be looking for integrity of that aortic valve. And then most of these lesions, ventricular septal defects, do have a lot more complicated physiology and often come with other lesions. So the other lesions that we're looking for are typically some form of our right ventricular outflow tract obstruction. For these patients, you're going to think about similar things to our ASD. When we have a hemodynamically significant shunt, that would be an indication for treatment and closure of this defect. If you're seeing chamber enlargement, specifically on the left side, again, you have to take this into consideration with our pulmonary pressures. If our pulmonary pressures cannot tolerate closing that that defect, we're going to have to, it may be a contraindication to closing a VSD. But in this scenario with the VSD, we're also going to look at that aortic valve and history of infection as indications for treatment. There's a similar treatment algorithm within that guideline, the ACC-AHA guideline, that goes over when and how to treat VSD. So moving on to right-sided obstruction, these lesions can really present anywhere along that right side, from the tricuspid valve all the way to the branch pulmonary arteries. And often these lesions come in pairs on the right side. The pathology here that I wanted to review was just Tetralogy of Fallot. It is relatively common in congenital heart disease, and the four main components of a tetralogy are pulmonary stenosis, right ventricular hypertrophy, an overriding aorta, and a ventricular septal defect. So when we repair a tetralogy of Fallot, this usually happens before the age of 1 or around the age of 1. And the repair is always going to involve the pulmonic valve and relieving this obstruction that is part of the right ventricular outflow tract. So the complications that I think about in adulthood relate to the fact that the pulmonary valve and the pulmonary annulus has been disrupted. Often this leads to some form of pulmonary insufficiency, and over years and years of pulmonary insufficiency, it leads to RV enlargement, which again, any chamber enlargement is going to predispose to arrhythmia. And that valve apparatus is closely related to the aortic valve as well. So a lot of times we have to watch out for aortic root aneurysm just based on the repair that had been done for patients. The considerations in adulthood is going to be mainly for our cardiologists, but as an internist, I just want everyone to understand the idea is that if I replace a pulmonary valve in a young patient, I want that valve to now survive with this patient. So how long will that valve actually be viable in this patient is also another consideration that's going to be on the table. Moving on to left-sided obstructions, these lesions also come in pairs or multiples. We can get obstructive lesions anywhere from the mitral valve all the way out to the aorta. And our typical lesion here that I want to go over is a coarctation of the aorta. In adulthood, this typically will present with secondary forms of hypertension. Often patients who have multiple agents for blood pressure, but really are quite uncontrolled. The way that we should screen for this, often patients can get ABIs, which show a differential blood pressure in our upper and lower extremities, or we can actually just take 4-limb blood pressures in our clinic. I just don't see that done often. If you have an upper and lower extremity differential, coarctation should be part of your thought process here. Most often, patients are really well controlled from their blood pressure after repair, but the complications arise when patients either get a recurrence of their coarctation or get an aneurysm at the site of repair. These patients with a history of coarctation should at least once in their lifetime have an MRI because there is a correlation with cerebral aneurysm, and they just require regular thoracic aortic monitoring. These lesions typically present with a bicuspid aortic valve or have a higher rate of bicuspid aortic valve as well. For the complex lesions, these patients often know that they should know that they've had heart disease. Transposition of the great arteries, hypoplastic left heart syndrome are just 2 examples here. Most of the complications that we have from these cyanotic and more complex cardiac lesions are related to their repair, and they should be followed by a cardiologist, but I just want to make everybody aware that as more advances in surgical and endovascular techniques occur, we are going to be seeing more and more of these patients in the adult world, and we should just have familiarity that they're there, and we should always get our cardiologists on board because of their complex physiology. When we talk about their ongoing care, these are often conditions that I would anticipate that an internist is going to have to talk to their patients about when patients say, well, what am I able to do from an exercise standpoint? Mental health and having chronic illness is going to be a big factor. Endocarditis prophylaxis, when we talk about dental work and any other scenarios, perioperative medicine, as in this case that I just presented. Pregnancy will put a large stress on the body and that heart physiology. And then should these patients, what kind of contraception do you want to consider if somebody has a right to left connection within the heart? All of this falls under the idea of transitioning to adult care. Often these patients are maybe more symptomatic when they're children, maybe asymptomatic. And when somebody feels asymptomatic, it's often forgotten. So the idea as we transition these patients into adult care, more and more it's going to be important to make sure patients have knowledge of their care. They have an ability to find knowledgeable providers, even in the adult world, that insurance covers these types of visits for patients, and that we just provide the best overall care that we can for these patients. There has actually been some data that shows that care at a combined program leads to better outcomes for these patients because it assures a smoother transition for adults and young adults who are then able to promote awareness of their disease so that they can have ongoing specialized care throughout their life. So this is kind of from our guideline. There's also a lot of information from gottransition.gov, which is a great resource to be aware of when you're trying to find resources for patients as they move from the pediatric world into the adult world. So these are my references here, and at this point, I'll take any questions.
Thank you, Dr. Dedania, for a very nice presentation. You had towards the end of your discussion how mental health issues are an issue with this population. Can you be a little bit more specific? And is it because of their congenital heart disease they have mental health issues, or is there some other connection that we should be aware of, and how might we best support these patients?
I don't think there's a direct correlation to say that their mental health condition may be caused by their congenital heart disease, but I think any child who has a complex disease in their childhood often has various mental health conditions, and it really depends on the amount of support I think that is surrounding them. That is really out of our area. It can come from anxiety, depression. There can be a lot of anger and resentment as patients, especially going through those teenage years. That's often where we get these young adults who have been rebelling against their disease from childhood. And when they present back into care as an internist, and I see these patients, the biggest concern that I have is really trying to get them connected and really taking charge and taking responsibility for their care. That's often how I see the mental health perspectives come up in young adults.
Thank you. Dr. Marcus, you have a question.
Yes, thanks. That was a really great talk. Thank you so much, Nishi. So I had a couple of questions. One was about the patient. Did previous people notice her murmur? Because he said it sounded like she had a pretty pronounced murmur. I mean, and I'm guessing that she didn't have any long-term sequelae from the previous strokes that she'd had decades prior.
Yeah, so that's a good question. I did not see that murmur documented in other notes. This pre-op evaluation was one of the first times that I had seen her in clinic. And really throughout her other medical history, I didn't see the murmur that was documented. In terms of the stroke also was not documented in her chart. And when I did a neuro exam, she had mild decrease strength on the left side that she says was all residual to the stroke, but it would require a pretty extensive neuro exam to see that. She did not have gross motor deficits. So it was actually pretty lucky for her, but that also meant that this was not known in her disease.
My other question was about the repair when people are babies. I'm wondering what kind of valve they use, because I'm just not aware of that subject at all.
I think there are actually multiple types that you can use. I think there are at that point, when especially in, I think you're talking about the Tetralogy of Fallot repair.
yeah.
So I think my understanding, and I am by no means a cardiologist, that pulmonic valve, that whole annulus that's actually narrowed is opened and patched. So they actually use probably, don't know if it's bovine, I actually don't know exactly what material they use, but they open and create a patch there as they, as you can imagine, a 1-year-old, all of this anatomy is going to increase and grow as the child grows. They patch as large as they can. So they're accepting that they're going to have pulmonary insufficiency. You're not recreating that valve there, from my understanding. You're accepting pulmonary insufficiency to the point where often patients feel fine and they can compensate pretty well. But when they get to adulthood, many of these patients with tetralogy presents with massively dilated right ventricles that are often leading to arrhythmia more so than heart failure.
Thank you.
There's one other question in the comments. If the ASD is not hemodynamically significant, do they require stroke prophylaxis? In the guidelines that I referenced, there was no mention of stroke prophylaxis. So none of these patients, even with an ASD, are automatically placed on any sort of stroke prophylaxis. My patient was actually on anticoagulation from what I understood and what she understood from her multiple myeloma standpoint.
Dr. Weiss, you're muted.
Thank you. And Dr. Lowry has her hand raised.
Yes, I just want one comment on all of you that may be following patients with congenital heart disease lesions. Please, if they're female, address their pregnancy risk. I received them as an adult, usually in their second trimester of pregnancy, with little options at that time. So please address the pregnancy risk. If not, please refer them to me and I will assess their pregnancy risk, preferably before they're pregnant. Thank you.
Okay, thanks so much for a great discussion and presentation.
Thank you, everybody.
Dr. Saul.
So much, Dr. Dedania. Now, to introduce one of my mentors and our second grand round speaker, Dr. Antonio Martin Jimenez. Dr. Jimenez is an associate professor at the Department of Medicine. He completed his
No. Oh, you don't want to say it anymore?
school at Universidad del Zulia in Venezuela, followed by internal medicine residency and hematology oncology fellowship training at Rush University Medical Center in Chicago. While in fellowship, he also pursued a master's in clinical research and went on to complete a fellowship in stem cell transplantation and cellular therapy at the University of Texas MD Anderson Cancer Center. Before his appointment here at the U, he served as assistant professor at Rush University. Dr. Jimenez is a prolific scientist, being the principal investigator in several funded trials to further advance the care for patients with high-risk acute myeloid leukemia, doing allogeneic stem cell transplantation, developing novel targeted therapies, and allogenic engineered T-cell treatments for these patients. He's a network transplant center chair at the Access Phase 2 trial, evaluating HLA mismatched unrelated donor stem cell transplantation using post-transplant cyclophosphamide. He has authored 2 book chapters and published several impactful manuscripts, including at the Journal of Clinical Oncology and Leukemia. He holds editorial responsibilities at the Journal of Transplantation and Cellular Therapy and in several leukemia and cellular therapies working groups. He sits at the advisory board for the National Marrow Donor Program as an outstanding teacher and mentor to residents and fellows here at the U and at his previous appointments. Finally, he co-founded a nonprofit named Art for Health that provides funding to medical missions to underserved communities in the Dominican Republic and Haiti. It is my absolute pleasure to welcome Dr. Jimenez to our grand rounds.
Thank you, Eduardo. That was an incredibly generous introduction. I want to thank everyone for
for joining. And again, I want to thank the Department of Medicine for this opportunity to present some of the work we have been doing at our division in an effort to expand transplantation access to minorities with the use of mismatched transplants. So try to share my screen here. And okay. These are my disclosures. In ways of background, hematopoietic cell transplantation is a curative treatment strategy for most hematologic malignancies, and the best outcomes are typically reported in the setting of a well-matched HLA donor. Current registries list close to 40 million potential volunteer donors, but the reality is most patients in the US lack an HLA matched donor. And for those who belong to a racial or ethnic minority, there is a disproportional disadvantage in this regard. The use of alternative donor grafts, such as haploidentical or half-match, umbilical cord, and most recently, mismatched unrelated transplants are all suitable options for those patients without a fully matched donor. I want to share some basics for the non-transplanters in the audience in terms of HLA and transplantation 101. For many years, one of our dogmas in transplantation has always been to aim for a fully matched donor. And to this day, the gold standard continues to be transplantation with a full matched sibling donor. We inherit our HLA in a Mendelian manner, and half of that comes from our mom, half of that HLA comes from our dad, and we inherit these HLA markers as a block or a haplotype. So by definition, we are haploidentical with our parents, we are haploidentical with our kids, and there's a 50% chance that we are haploidentical with each one of our siblings, and 25% chance that we're fully matched with each one of our siblings, given this pattern of inheritance. For the purpose of my presentation today, I'll be referring to an 8 out of 8 donor as a fully matched donor. And that is a donor and recipient paired at alleles A, B, C, and DRB1. And the reason why these alleles are so important is because they're highly immunogenic and more likely to mediate graft versus tumor and graft versus disease responses that are likely to impact transplant outcomes. Single disparities in each one of these alleles is associated with an increased risk of GVHD or graft versus host disease and non-relapse mortality following transplantation. Graft versus host disease, it's a multisystemic disorder in which alloreactive T cells from a non-identical donor, this is the graft, recognize the recipient tissue as foreign, initiating an immune reaction that causes multi-organ disease in the recipient. GVHD could affect potentially any organ, but typically in the acute form tends to affect the GI tract, liver, and skin, and it could be potentially fatal and obviously a significant complication of allogenic grafts. Our utilization of allogenic transplant has increased exponentially over the past decade or two. And this is a result of many factors. We have an aging population, emerging transplant indications, better target therapy, better supportive care, and improvements in HLA typing and an increasing donor pool. But through this, transplant is incredibly expensive. It's a very expensive treatment. It's very labor and resource intensive, and is therefore associated, unfortunately, with disparities in access. There are many socioeconomic, provider specifics, and healthcare system barriers to transplant that are listed here. I'm not going to go into all those in detail, and I'm going to focus mostly on biological barriers, namely donor availability. When it comes to donor availability, as I mentioned before, there is a significant disparity based on the patient's race and ethnic background. And this is what that disparity looks like. This is data from the National Marrow Donor Program showing the odds of finding a fully matched donor, or again, an 8 out of 8, donor and recipient match at A, B, C, and DRB1 on the basis of race and ethnicity. All the way here to the left in green, we can see that if that patient is Caucasian or Caucasian, the likelihood of finding a said donor, it's close to 80%. But if the patient is Hispanic or Latino, that number drops to less than 50%. And for an Afro-Caribbean or African-American patient, that number is less than 25%. And for those patients that are even more mixed, the likelihood of finding a fully matched donor in the registry, it's pretty slim, as our HLA is tightly correlated with our race and ethnicity. If we allow higher degrees of mismatch, say we use a donor from the registry that is 7 out of 8 or 6 out of 8, picture here in the orange and green bars, then the likelihood of finding a donor, it's higher. But again, it continues to be always the highest for Caucasian patients. And while we can use MMUD or these mismatch unrelated donors for minority patients as an option, and for many patients, this is truly their only option, we pay a price when we use these mismatched donors. This is also data from the National Marrow Donor Program showing that with each degree of mismatch, there is an impact in survival, making any transplant less than 7 out of 8 essentially prohibitive, given high risk of non-relapse mortality following transplantation when traditional GVHD prophylaxis is used. That in the US, it's typically a combination of thymoglobulin or ATG, methotrexate, and calcineurin inhibitor. So despite increased transplant utilization, there remains a truly unmet need to expand access to transplant to minorities. And the use of alternative donor grafts is a potential solution to this problem. Umbilical cord blood transplant obviously is not a new strategy. It has been around for decades. One of the main advantages of using a cord blood for transplantation is that the cells in a cord blood are more immunologically naive. So it allows us to proceed with transplantations with higher degree of mismatch with lower incidence of graft versus host disease, which is of course a very attractive option for minority patients. Since the units are already banked, these are readily available, and there's really no risk to the donor. The main disadvantage of cord blood transplantation is a limited cell dose. The amount of cells in a single cord unit, it's only able to support hematopoiesis in a patient of up to 50 kilos, which obviously becomes a problem in adult transplantation. Due to low cell dose, we obviously encounter issues with delayed engraftment, delayed immune reconstitution, increased infections, and high non-relapse mortality. And most importantly, we know from projections that even when we are permissive to use highly mismatched cord units, the current inventory is not sufficient to bridge this gap or to support transplantation in these minority patients without suitable donors. A far more popular option is the use of a haploidentical transplant. As I mentioned before, we are haploidentical with our parents, with our kids. And again, there's a 50% chance that we could be haploidentical with our siblings. So in theory, there is a haploidentical donor available for most patients. And with the use of novel anti-rejection and GVHD prophylaxis, we can perform these highly mismatched, remember these are half-matched transplants, with very acceptable rates of non-relapse mortality and GVHD when we utilize cyclophosphamide following transplantation. And I'll elaborate more on that in a second. Some of the concerns with haploidentical transplantation, increased relapse, increased infection, and increased incidence of graft failure. The use of cyclophosphamide truly revolutionized the way we do transplants. Cyclophosphamide is clearly not a new drug. It's an alkylating agent that has been around for many years with multiple uses in chemotherapy and immunosuppression. And it's given following mismatched transplants on days 3 and 4 after transplantation, based on the immune rationale that the recently activated alloreactive T cells that are responsible for graft versus host disease are particularly sensitive to the cytotoxic effects of this drug. But somehow the rest of the T cell repertoire, the regulatory function of these T cells remains somewhat spared, which avoids the widespread immunosuppression that we typically see in mismatched transplantation, and that is responsible for this very high mortality. So since the early 2000s, we have been using haploidentical transplant, and it remains to this day perhaps the most common alternative graft source for patients who do not have a fully matched donor. Moreover, there is phase 3 data, large CTN 1101 study. I'm not gonna go into the details of that trial, just to say that the trials show that survival appears to be better on patients receiving a haploidentical transplant compared to cord blood transplant if they do not have a fully matched donor, at least on the reduced intensity conditioning setting. Some additional barriers to haploidentical transplant, though, are for older patients, their donor age can be a problem. If you have a patient that is 60 years old, then of course their parents are going to be much older, same with the siblings. Graft failure can be seen when patients have donor-specific antibodies. This is not uncommon in haploidentical transplant. For certain hematologic disorders, germline predisposition in family members could also be a barrier. And a very important one is logistics. And this is something that we see, I will say, weekly in our clinics, and particularly relevant for minority patients who are immigrants. In theory, most patients have an available haploidentical donor. But in reality, for many of our immigrant patients, they can have young and healthy parents, young and healthy siblings that are all potential haploidentical transplants, but they simply can't travel to the US to complete mobilization and collection. And mobilization, collection, and shipment of these cells at their home countries is just logistically impossible, which does not allow us to do this transplant in a timely manner. And you know, unfortunately, haploidentical transplant is not an option for this group of patients. And again, this is not an uncommon scenario that we face, I will say, every week in our clinics here. So for those patients in which we can use cord blood transplant or a haploidentical transplant, what can we do? And this is where mismatched unrelated donor transplantations, or MMUD, are emerging as a very attractive alternative graft source, and one that we have been using at the University of Miami for many years now. In an effort to expand this access to transplantation, and encouraged by single institution data of MMUD with cyclophosphamide, including data from Sylvester, the National Marrow Donor Program sponsored a phase 2 study, which was led by Sylvester. This was the 15 MMUD study. In this study, we enrolled 80 patients between 2016 and 2019, and these patients received a mismatched unrelated donor graft. That is, a donor from the registry that was matched at the 7 out of 8 level or less. So anywhere between 4 out of 8 and 7 out of 8. Patients receive a standard reduced and myeloablative conditioning. This was a non-randomized study, and the graft was bone marrow, and GVHD prophylaxis with cyclophosphamide, calcineurin inhibitor, and mycophenolate. The primary objective was to determine 1-year survival following this modality of transplantation. And our primary hypothesis was that 1-year survival following mismatched transplantation will be 65% or higher, which the number came, it's comparable to the 1-year survival that has been observed after haploidentical transplant. We also hypothesized that the majority of patients will achieve engraftment meaning a functioning bone marrow, with most of these patients achieving a near full donor chimerism, which is one of the metrics we follow, by 2 months. And we will be able to achieve that with acceptable rates of grade 3 and 4 GVHD and non-relapse mortality. I want to bring your attention to this figure here, and that is 48% of patients on this trial belong to a racial or ethnic minority. And this number was pretty impressive to us and really unprecedented, not only for a National Marrow Donor Program study or CIBMTR, which were the sponsors of the trial, but truly for any prospective trial in medicine, this high participation of minority patients. Another key figure that I want to share with you, if you see here to the left, 38%, close to 40% of patients on the study receive a highly mismatched graft. This is 6 out of 8 or less. And this is very important because if we are permissive to that degree of mismatch, if we can do a 6 out of 8, 5 out of 8, a 4 out of 8, and I'll take you back to the figure I shared with you earlier, that essentially means that we could offer a transplant to any patient that walks through the door, irrespective of their race and ethnicity. But what I think is more important here is that by having an increased donor pool, we can optimize other non-HLA factors that are well known to affect outcomes: donor's age, gender, parity, CMV and ABO status. So not only we could offer a donor to every patient, but we could offer a better donor to that particular patient we're seeing in clinic. The study exceeded its primary endpoint with a survival of 76% at 1 year, with no difference in survival based on the degree of mismatch or ethnicity of the donor and patient, and with very acceptable rates of acute and chronic graft-versus-host disease and non-relapse mortality, but all less than 10%. We compared the survival of this cohort of patients to historical controlled patients receiving haploidentical transplantation reported to the CIBMTR with cyclophosphamide, and patients receiving peripheral blood mismatch unrelated donors. And as you can see here, there was really no difference in survival. The outcomes appear comparable. And the conclusion from this study was the approach MMUD with PTCy was feasible and safe, with outcomes comparable to other settings where cyclophosphamide was used, such as haploidentical transplant. To me, the key finding here is half of the patients on the study belong to a minority, which effectively means that MMUD with cyclophosphamide has the potential to broaden access to transplantation for these patients. We transplanted last patient in the study in 2019, so we have long-term data to present. We presented this at EBMT earlier this year, and we can see that 3 years out, we continue to have a survival close to 70% with a non-relapse mortality of 12%. And importantly, we found no difference between the single antigen mismatch and highly mismatched patients, which gave us a very early reassurance that we can safely expand transplantation to patients without fully matched or single antigen mismatched donor. One key question is there a preferred GVHD prophylactic strategy for mismatch unrelated donor transplant? Or put differently, how does the cyclophosphamide platform compares to our standard GVHD prophylaxis with thymoglobulin or ATG, methotrexate, and tacrolimus or sirolimus? The European Bone Marrow Transplant Group answered that question a couple of years ago now on a matched pair analysis. This is work from their Leukemia Working Party. They compare the outcomes of 272 patients with acute myeloid leukemia receiving ATG versus cyclophosphamide. The primary endpoint was severe GVHD. And they found that the rates of graft-versus-host disease were significantly higher, twice as high, in fact, in patients receiving ATG, resulted in better leukemia-free survival, better GVHD-free, relapse-free survival, and a trend for better overall survival in patients receiving cyclophosphamide. This study, we have to remember, it was limited to patients with acute myeloid leukemia only. And unfortunately, we had no information about the genetic or racial makeup of this cohort. At Sylvester, we explored the same question also a couple of years now, a little bit almost 2 years ago. These are transplants, again, that we have been doing for many, many years. We start this program, quite frankly, out of necessity, given the population we serve. And we felt that Miami was really the ideal place to explore how to improve mismatched transplantation. Miami is truly a city of immigrants. This is data from the latest census. So we can see here, the majority of patients in the Miami-Dade country are foreigner. And this is something that we, not us, but I will say probably everyone across the institution see reflected in their clinics every week. So as a program, we had an urgent need to expand transplantation access, but also to improve the outcomes of mismatched transplantations for all of our patients. We combine our efforts with colleagues from Sloan Kettering Cancer Center in New York. They also serve a very ethnically diverse population. And we compared the outcomes of 128 patients receiving mismatched unrelated donor transplants between 2016 and 2020. Sorry. Some of these patients received PTCy, and we compare this cyclophosphamide group to patients receiving a traditional GVHD prophylaxis with ATG and methotrexate that up until then was our standard of care. 2/3 of patients in this group identify as a racial or ethnic minority, and 1/3 of patients receive highly mismatched graft, that is 6 out of 8 or less. And our primary objective was GVHD-free, relapse-free survival. So this is survival without relapse and without severe GVHD. The groups were well matched for transplant indication, acute myeloid leukemia being the most common, high-risk disease, comorbidity index, and the use of an ablative regimen. Patients that received PTCy were more likely to receive a bone marrow graft, and also were more likely to receive a highly mismatched graft. To the left here, we can see that the incidence of relapse was comparable for both arms, but the similarities pretty much ended there. Non-relapse mortality was more than double in patients receiving ATG, resulted in better GVHD-free, relapse-free survival, and significantly superior overall survival for patients receiving cyclophosphamide, 75% versus 45%. I didn't list them here, but every other metric, acute and chronic GVHD, GVHD requiring systemic therapy, also favor the PTCy arm. And 75% at 1 year for mismatched transplantation, it's pretty impressive considering the fact that, again, 1/3 of these patients receive a highly mismatched graft. I share with you some of the, okay, I'll try to go back, some of the data from multi-center from the NMDP with mismatched transplantation. And more importantly, we didn't exclude patients with active disease. So we were very encouraged by these results. While non-relapse mortality was higher for patients receiving ATG, disease relapse remains the leading cause of death in these patients. And this is one of our other areas of research interest. Hopefully we can present some of that data to you guys later. And for a subset of patients, we were also able to evaluate immune reconstitution. We found that while there was similar lymphocytic reconstitution, patients on the ATG arm had lower CD4 to CD8 ratios, and again, not included here, but significantly higher rate of CMV and EBV reactivation and disease, and delayed B-cell recovery at 12 months. We concluded that despite a higher degree of mismatch, MMUD with cyclophosphamide resulted in better outcomes compared to ATG-based prophylaxis, which up until that point was our standard of care. Outcome following transplant, they're really comparable between two haploidentical transplants, and at least in our own experience, are comparable to fully matched unrelated donor controls. And it's a safe and effective way to offer transplant to minority patients that do not have a fully matched donor. We perform this trial again in 2 institutions, and the 9 other centers that were highly specialized transplant centers with expertise in mismatched transplant. But we were interested in knowing if we could expand this approach to other institutions. And with that in mind, we wanted to explore this approach in pediatric patients, and again, at more centers. We designed a second study called the ACCESS trial.
One minute remaining, Dr. Jimenez.
Yeah, I'm almost done.
Okay.
We designed a second trial called the ACCESS trial at other 40 different institutions across the US, evaluating a similar approach with peripheral blood. And in the interest of time, I'll just fast forward to our metrics today. We have conducted the study in 40 institutions, and these are our accrual to date. We have over 100 patients, and despite starting this in the middle of the pandemic and facing some drug shortages, the accrual has exceeded our expectations that tell us that there is really an unmet need in transplantation for these patients. Last, I want to say these studies go beyond simple biological factors. We know that minority patients are more likely to have inferior outcomes following transplantations, even if they get to have one. And I want to quickly present some data that one of our chief fellows, Dr. Ayer, presented at the AACR last year. We compare outcomes of minority patients versus non-Hispanic whites. This was also supported by a catchment area grant at Sylvester. And what we can see here is that there was no difference in outcomes in survival or any other metric between non-Hispanic white and minority patients. Again, I think this is not a result of using cyclophosphamide. I think this is a result of a multidisciplinary effort from a lot of people at Sylvester, including inclusion in clinical trials, collaboration with our colleagues in hematology, and early referral and partnerships with NMDP. Just to summarize, last slide, despite increased transplant utilization, access to transplant is an area of unmet need, but the use of mismatched transplant with PTCy is safe and feasible with acceptable rates of mortality and post-transplant outcomes. And other non-biological barriers to transplant for minority patients were not addressed today, and they require equally important attention. With that, I want to thank you, everyone, and be happy.
Thank you, Dr. Jimenez. That was a very impactful and important presentation that encompassed health disparities and really highlighted the robust transplant center that you have and we all have here at UHealth. So congratulations for all of that. We're at the top of the hour. I remind everybody to go to the link in the chat for the CME credit and to answer the MOC questions. And our prayers are with all our neighbors to the north, that they should be safe and all our families dry in the coming hours and days of the current hurricane. So wishing everybody safety and wellness, and we'll see each other not next week, but the week after. Take care.